who are putting this on, West Virginians for Affordable Healthcare, Canal Valley Village People, Fair Shake Network, Citizen Action Group, and Gary Zuckett is going to be live streaming this, and also Create West Virginia. Corey Zinn is also going to be videotaping us. So thank you so much for coming. And now I would like to introduce the moderator, who will also introduce the other panelists, Dr. Chris Klein, who is Professor of Public Administration at WVU, and much else. Thank you.
Thank you so much. How is everybody? It's a Sunday fall afternoon, so we need to get energized, right? What a beautiful place this is. It truly is. And it's public places like this that allow us to get together to talk about very complex issues. And that's why we're gathered here today, whether we're here in person or streaming online. Today is an opportunity for us to talk about really one of the most challenging issues that we face, and that is ensuring that people have access to healthcare and coverage for healthcare. Now, I'm in the enviable position of being able to be surrounded by really, really insightful, expert, and experienced minds who are able to provide, I think, a full picture as we talk about healthcare and healthcare for all. How many of you would agree with me that healthcare is an important issue? That's easy, right? How many of you all would agree with me that healthcare is an emotional issue? Absolutely. A technical issue. Yes, a complex issue, right? And so, as we encounter complexity, we need to sort of get a sense of the landscape in which we will have our discussions. And so today's agenda is far-reaching because it allows us to help understand what is happening, if you will. And I'm going to give you a cool picture here. Time and space. Okay? I was just talking to a friend of mine about how much I love time and space. I love looking out on a clear West Virginia evening and seeing the stars above. I'm sure you all like to do that too? Yeah. Yes. All right. I need a little bit of, And so I often think about public policy issues in context of the broader themes of what has happened over time and what happens across space. Okay? Now, I know that sounds really cosmological, but it's really simple like this. Today's choices are shaped by what? That which has happened in the past. So we experience healthcare today in context of what's happened over the years, over decades, and even over centuries. So we always have to think about time and the way that time shapes who we are and where we're going. But we also have to think about healthcare in terms of space, if you will. And this is very, very important. If we think about healthcare, it's not the only policy issue out there. It's not the only pressing social concern that we have. Indeed, what we have to wrestle with is the fact that healthcare has to be seen in context of other public policy issues, other pressing social issues, other demands that are facing us. And we have to look across space to help to find answers and solutions and ideas so that we realize that we're not completely isolated. That we can learn from other countries, we can learn from other states, we can learn from other experiences. So if you will, consider the fact that we benefit but are also shaped by the past. And we benefit and we can profit from studying that which is all around us. Or, if you want, think about a beautiful night sky and think of time and space. Okay? That was my graphic. You like it? Good. Now, my job today is really just to sort of help to set the context. And really to help to, in many ways, for us to understand some of the ideas that we're going to be talking about today and how we got here. So the first thing that I suggest to you all is that I think it's really important for us to keep in mind the idea of path dependency, or incrementalism. Now, many who have studied healthcare in our country and elsewhere recognize the fact that the structures and the systems that we have today are a product in many ways of decisions that were made decades ago. Atul Gawande, who's a wonderful writer and an MD, look at it back there, okay, has written extensively on healthcare. And in 2009, he wrote a wonderful article about path dependency to help us to understand sort of the constraints and the opportunities that we have in the United States as far as the path forward with healthcare. And indeed, this article appeared in the New Yorker magazine, had a great broad reach. The idea behind path dependency is shared by many. And all you need to do is think about the following ideas and think about the following observation. How many of you here are familiar with Medicare? See, I'm all about this audience participation today. I had a long, lonely drive down from here. How many of you are familiar with Medicaid? Sure, okay. Now we know that we can trace both of those programs back to when?
1965.
Love that, yes, 1965, right? And the Medicare and Medicaid were produced as amendments to the Social Security Act of 1935. So the architecture, the template of those two absolutely crucial public policy programs find their roots not only 53 odd years ago, but also all the way back to the 1930s, if you think about it. And the reliance that we have on the healthcare system that we have, whether it's the insurance system, the provider system, are all a product of those evolutionary forces, if you will. Medicaid, as Sharon Carpenter is more than qualified to talk about, and CHIP, well, they evolved tremendously under this original infrastructure that was adopted in 1965, but look much different than they did back then, right? Absolutely. So one of the things for us to always keep in mind is that as we consider healthcare and health policy options now and in the future, we have to remember how the past has shaped it. And I love what Gawande had to say, that with path-dependent processes, I'm not going to look back there the whole time. With path-dependent processes, the outcome is unpredictable at the start. Small, often random events early in the process are remembered, continuing to have influence later. Some of you might think about this in another term. Public policy decisions often have intended consequences, but they also have what? Unintended consequences, okay? If I sound like I'm lecturing, that's what I'm doing. I'm a professor. Okay? No, but it's important to get some of these ground foundations out there. We also know that healthcare has a social dimension. If you've not read this book, I highly recommend it. It's by Charles Rosenberg. It's called Our Present Complaint. It's about American medicine then and now. The book is almost a decade old, but it really gives us a sense of understanding that we cannot talk about health policy or health care without understanding the broader social context in which we live. Our choices, our priorities, even our way of conceptualizing healthcare are a reflection of the times that we live in. Our conception of healthcare today, I think all of us would agree, is much different than it was 30 years ago, 60 years ago, 100 years ago. And yet, our healthcare system reflects some of the old architecture. And so we have to wrestle with that. In fact, one might say, and various authors have, including Rosenberg, that we live in an era of postmodern medicine. Now think carefully about this. How many of you have heard of postmodernism? Yeah, it's kind of cool stuff, all right? But it's also very serious. It talks to us about the fact that we, as a society, conceptualize power relationships, institutional relationships, expectations in different ways than we may have just a few generations ago. This is very, very important. How many of you are healthcare providers? One. Anybody else? Okay, two. All right. Three. Has your relationship with patients changed over the last 15 or 20 years? Probably. At times, people may be saying, look, I've done research. I think this is what's wrong with me. Have the expert claims of healthcare providers been challenged at times? Yes, I think so. Whether it's on a patient-to-provider basis or whether it's societal. Okay? Think of the debates that we have over vaccines. Think of the debates that we have over preferred medical models. That's a reflection in part of this postmodern society that we have in healthcare. Have our expectations changed in terms of healthcare delivery? Do we want to have choice? Do we want to have autonomy as patients? Yes. Are we as quick to defer to the expert opinion of others? Probably not. Okay? So postmodern healthcare tells us that the relationship between provider and patient, the provider and the public changes. It tells us that sometimes that knowledge claims may be challenged. It also means that people expect to have more choice and options. Now, I could go into a very long discourse on this, but it's important for this to be part of our understanding. Is that in an era of postmodern medicine and healthcare, we have heightened expectations. There's a little bit more uncertainty about the expertise and the science that is out there. We also realize that the postmodern world is also a complex one of competing economic interests and models and methods to deliver health care. And we've seen that in the last few years. Here's something else. And this, again, my job is to help to set context. Let's think about postmodern healthcare in the political context. Do we live in a world of hyperpartisanship? Gary's nodding, said yes, thank you very much. Anyone else agree?
Yeah.
Right? Yeah, the chasms and division points, the conflict points seem to be so much more intense. Think about a meeting in this room 20 years ago. Think about a meeting in this room 50 years ago. To talk about politics, to have campaigns present their perspective or viewpoints. The discussion perhaps might have been more respectful, more inclusive. We live in a time of hyperpartisanship. We need to understand that any discussion of healthcare policy occupies a highly partisanized arena and time, which means that a special priority has to be placed upon evidence, compromise, civility, understanding, empathy. For if we don't do it, who will? In a time of hyperpartisanship, we need to find ways to find common ground and common purpose. When we talk about the complex, technical, and emotive aspects of healthcare, we need to keep that in mind. Not to fall into the undertow of hyperpartisanship, but to swim in a way that we can get out of that. We also know that we live in a time of single-issue politics and campaigns. Now, this has been part of the political landscape for quite some time. But here I offer a warning. If we are to talk about solutions to healthcare coverage and access issues in our country, we need to be careful about having those become compartmentalized or characterized as single-issue matters. Health policy is very complex. Those of you who live health policy, live healthcare, know that there are many dimensions to it. And a reducible formula that brings it down to one single answer or to one single perspective probably is not the best way to describe the situation, and for those who are interested in advancing the policy ideas, may not be the best path to take in terms of advocacy. We also realize that in this time and day and age, we have uncertainty about the origins of ideas and who is promoting those ideas. Many years ago, political scientists talked about astroturf movements. An astroturf movement would be in what? Comparison to what? Yeah, okay. So a grassroots movement, you tend to think of organic and from the bottom up. An astroturf movement is what? something that's kind of manufactured. Myself, I like watching my sports on real grass. Okay? We also realize that there's a tendency in this day and age to frame things in absolutist terms rather than to think about compromise. Clearly, what you're hearing from me is a civics lesson right now. That we live in a time of hyperpartisanship. We live in a time when mobilization of support or ideas may not necessarily be organic, but may be more manufactured. And we live in a time where even though we may be tempted to fall into the hyperpartisan rhetoric, more so now than ever, it's absolutely crucial for us to try to find common ground and to try to convey to others the complexity of those issues that we're concerned about. I'm not going to spend too much time here, but just to remind everybody that oftentimes in our country and in our political situation, especially those who are not as engaged and involved in politics, we tend to think about politics as being executive-centered, whether it's at the presidential level or at the gubernatorial level. And that's the case in all 50 states when we talk about the gubernatorial aspect. Okay? We tend to think about politics as being the domain of the president or governor. It's much, much more. And again, it's simply a reminder that policy ideas emerge in many different contexts. Policy debates and conflicts play out within legislatures and within the courts themselves. Many of the most incredible innovations in healthcare have emanated not at the federal level, but where? At the state level. And yet some of the most stark challenges to healthcare have also emerged at the state level. We cannot forget the states when we talk about health policy, when we talk about new ideas for healthcare coverage and access. Those laboratories of democracy, which Justice Brandeis talked about so many decades ago, continue to do their work and are important to understand. But also important to understand that the lessons learned from one state or the experience in another state may not be readily be transferable to ours. Now, a big part of the discussion today is going to be about Medicare and Medicaid. And I don't want to steal the thunder of my fellow panelists, and I'm also being very mindful of time. But I would like everyone to think about the fact that both Medicaid and Medicare have a tremendous footprint in our health policy system. By their virtual size, they've helped to shape the contours and the landscape that we live in. I'm going to fast forward to 2016. These data are from the Kaiser Family Foundation, and it just sort of gives you an idea of just what the presence and prominence of both Medicare and Medicaid might be. And these are unduplicated numbers, in fact. So what I'm saying here is that the Medicaid enrollment and the Medicare enrollment are separate. Dual eligibles are included under the Medicare numbers here. And so you can see that across the United States, that 19% of Americans are covered by Medicaid, an additional 14% are covered by Medicare. Look at our state, 26% and 18% respectively. I simply have those numbers up there to further illustrate the importance that public policy and government, whether it's at the state level or the federal level, can play in shaping the healthcare landscape and in providing the platform, those policy platform, that policy architecture for us to make adjustments and change. With all of this in our discussion today, we want to consider and understand the importance of political context. We need to understand budgetary politics. Okay? The programs that we're talking about, such as Medicare and Medicaid, are major features of the federal budget, and Medicaid, of course, is a major feature of our state budget. We need to understand interest group politics. Medicaid and Medicare benefit not only you and I as individuals, but Medicaid and Medicare benefit well-organized, well-established interests, whether they're hospitals, federally qualified health clinics, providers, managed care organizations, pharmaceutical companies, you name it. Medicare and Medicaid are not simply about the people they serve. Frankly, they also reflect highly organized, highly complex, highly interdependent web of interest. We must keep that in mind as we talk about these programs. Finally, I think it's really important when we talk about the political context is that we're careful, and I feel very passionate about this because I spent a lot of my career studying Medicaid, is that we don't blame the victim. It's all too often, it's all too easy to talk about Medicaid fraud and abuse being the domain of the beneficiary. There's discussion and talk today about work requirements. I simply would ask individuals, as a political scientist, to learn from history, to learn from our own past experiences, and to understand that the way forward in providing healthcare coverage and access, the way forward must give careful consideration to past efforts and attempts to impose work requirements or other requirements on those who are receiving health insurance. Just some numbers I'm going to put up here. I'm just going to look at those in terms of Medicaid spending in the United States and in West Virginia, as well as some of the Medicare aspects. So when we talk about Medicare, for example, Medicare for all, do keep in mind the cost aspects of this. And that projected cost for Medicare, according to the Kaiser Family Calculation, is estimated to, it will be estimated to exceed $1.28 trillion in 2028. There's my picture again. Y'all like it?
Time and space.
I did not take it. Okay. Yeah, it was all stock. Okay, but it was such a good picture. But I want you to think about this one more time. Time and space. We learn across time and space. We exist across time and space. I know that sounds pretty heavy on Sunday afternoon. But here's the big point that I want to emphasize. Just because we live in a time of constraint, just because we live in a time of hyper-partisanship, just because the past has shaped so much of our architecture of healthcare and influences our choices, it does not mean that we are simply riding along on solar wind or riding along like a leaf downstream of a West Virginia stream. We have agency. We have the ability to make decisions, to determine future courses. So just because things have been as they are, it doesn't mean that we are constrained completely in our choices moving forward. Path dependency, an appreciation for history, an appreciation for what's going on now as constraints and issues to consider, is not an excuse for us to ignore our responsibility, nor is it an explanation for our lack of agency, where I believe we have considerable agency to assess and to affect change as necessary. That is part of the great American experience and experiment. Today, we have an opportunity to talk about the state of things, but also to offer some ideas about the future that may be very close at hand. And so, what I'm going to do is I am going to first adjust my trifocals. Look at my panelists. Hi, panelists.
Hi.
Hello. Okay. And we're going to start with some discussion. And the first is a discussion on an incremental approach to reaching universal health care. And my dear colleague, Sharon Carter, is going to be our presenter. And she'll be followed by Dr. Dan Doyle, who will talk about coverage for all. and then by Kat Stahl, who will talk about state and federal issues. Many of you know Sharon as her time with West Virginia, the state government, and when she was the executive director for the West Virginia Children's Health Insurance Program. And also, she is the former deputy commissioner of West Virginia's Medicaid program. More importantly to me, Sharon, if you don't mind, is I know how committed you have been to health care in our state, to understanding the issues of coverage and access, and to being a tireless public servant in helping to ensure that individuals get the coverage that they are eligible for in our state. So, thank you.
Thank you, Chris. And I'd like to say thank you to all of you for being here and for the opportunity to talk to you about some topics that have preoccupied me greatly since I left graduate school in the early 80s. I should have told Chris to stay for the technical systems part. I'd really like to take a lot of time to focus on the space-time of the last 100 years. Before I start, though, I'd like to ask how many people here, who will help me gauge my audience, how many of you know that modern healthcare coverage started in Germany in 1883 when Bismarck introduced it? And not just sit on your hand. I have to say that for we're not born. But it is true. It was introduced by Bismarck, who was actually a conservative from the Prussian aristocracy, but he was part of a package of reforms that he was introducing, and a little political twist of irony is that actually his guaranteed compulsory health care coverage of workers was not supported by the German Socialist Party because they were afraid it would undermine their own platform. But we'll move along from there to talk about the first efforts in the United States come when Teddy Roosevelt begins his 1912 campaign and loses. He brings up the topic of health insurance coverage, again for workers. And then in 1915, you see on the timeline, I know these are small, but I'm really going to be talking about the highlights, and I think Shannon Hall told me we have some copies of this for those of you who might like to see this in great detail. Okay, thank you. They're in your folder. So in 1915, the American Association of Labor introduces model legislation in several states. Of course, it fails, but at least we see efforts that early. Also, in doing research for this, I was interested to see that in California in 1917, as many as 41% of union workers had some kind of coverage through a sickness fund, as they were called in those days. But really, if you look at this in the larger sense, 45 years go by before Harry Truman is the first president to actually introduce national health insurance legislation, and it fails in 1945. A lot of the things that I'm reflecting on this timeline, I try to reflect most of the legislation on the top and then system changes on the bottom, although there's a little bit of both there just to try to compact it in. But on the top, one of the most significant changes to healthcare is something that does not have anything to do with healthcare. And that is in 1942, Congress passes the Stabilization Act. And what is that? This is done in the context of World War II. Labor is scarce. So Congress passes the Stabilization Act, which in effect is a freeze on wages. That freeze makes workers very difficult to recruit without being able to offer any increases. So the The effect of that is that employers began to offer health care coverage and benefits as a way to recruit workers. This later becomes reinforced by IRS rulings, which make this a tax-free benefit. So if we whip along, then as Chris mentioned, it's really not until 1965 when we have LBJ, who is known as a master legislator. He's able, in the wake of the Kennedy assassination, to get Medicare and Medicaid through the Congress of the United States. And I think it's noteworthy, too, on the timeline. Many of us may have forgotten it, but Nixon introduced a very major piece of legislation and was assembling something that was called CHIP. It wasn't the CHIP that I'm familiar with, but it was the Comprehensive Health Insurance Program. And it had several things that it was intending to do. Many of them are intended to promote private insurance or grow that market through family health coverage. It would have decreased Medicaid coverage. It had an emphasis on HMOs that were new at that time. However, two scandals at this time occurred that even though there was major support for this, both from the president and from then the all-powerful Ways and Means House leader, who was Wilbur Mills. Do we know what those two scandals were? We know one of them was really easy, right? Watergate happens. Even though we were building a really strong consensus, the other was that unfortunately Wilbur Mills was a heavy drinker and ran into a fountain one evening with a call girl in his car, and that effort kind of crumbled. I think that these, on this timeline, you'll see both the gains and the losses are significant lessons. If we move to the next slide, things intensify. Even though we have Medicare and Medicaid at this time, still health insurance is not universal. There are still many efforts to tweak it. We have things like COBRA that allows people to take their coverage with them if they lose a job, assuming that they can pay all the premiums. But the really big next effort comes in '93. I remember this vividly. I sat in the home of the living room with about a half dozen other women who were anxious to see Clinton's inaugural, his first State of the Union message, where he held up, some of you may recall, he held up the health security card that every American would be promised. There were some women who were with me there in the room whose eyes filled with tears, thinking we were finally reaching universal coverage. But as we know, that was not to be true. So even after that, it's 20 years later before we reached the Obama years when the Patient Protection Affordable Care Act passes. It's a complex package. It's criticized for its length. People say that they haven't had a chance to read the bill, even though it was debated in committee for over a year. But it's a package of both individual protections, such as mandating the coverage of pre-existing conditions by insurance companies. It has a minimum loss ratio in it, saying that insurance companies must spend 85% of their expenditures must be on medical claims and not administrative overhead. It includes those and many other insurance reforms, and it expands Medicaid. However, as we all now know, that Medicaid expansion is only in effect in 30 of the 50 states because it was undermined by the Supreme Court decision, which took away the ability of the federal government to withhold funds to states that didn't expand. So we reached the end of our timeline, looking at, what what are most likely our next steps? And hopefully we'll all just have time to discuss that towards the end of our presentation. The next slide is simply reiterating some of the points that Chris had on his slide about where we stand today for coverage, both in the United States and West Virginia. And my figures too came from the Kaiser Foundation. Let's talk a little bit about why healthcare reform in the U.S. is so hard. We have so many factors at play. You can see from the history of how it's evolved. We have kind of a patchwork of complexity now of coverage and non-coverage. This complexity has been formed by cultural factors like individual and social responsibility. In the past, Medicaid coverage was something that was linked very closely to welfare. I think we're slowly evolving away from that notion, where now Medicaid, we have a significant number of people under Medicaid coverage who are working. The whole question of coverage is much more of affordability. We have the issue of dividing ourselves between state and federal approaches. It's easy to look at Europe, where they have much more centralized systems. You have one program for all, but we currently have 50 states that still have the individual authority over insurance regulation. We saw that debate in the last go-round. We have separate but interlocking factors of how we approach coverage in the United States as a matter of not just of policy, but how we finance it, whether it's public or private, and the delivery system. These are some of those pathway-dependent factors that Chris mentioned. And as President Trump pointed out, we now know it's complicated. So, lastly, as we think about how we go forward, I just wanted to share these 6 points that were written in a memo to the Clintons back in 1993. They were written by Ira Magaziner, who was the chief health policy architect in the Clinton administration. He talks about that the U.S. has never done anything as big or comprehensive as this. He points out that he thinks no one can win with an us versus them fight on healthcare reform. He talks about the best themes being security, cost control, prevention, themes that we've heard emphasized since that time. He feels that we can't win with a liberal coalition alone, that we have to have real and not token support from Republicans, business, and other provider groups. He says that we have to lead a search for consensus, and that we need to turn complexity into an asset. That's a really tough one right there, I'll tell you. So those seem as true to me today as they did back in the 90s. So lastly, I think we're just faced with a question that we all need to consider together of political feasibility. What would be our goals for going forward? I'm for things that are achievable, and I think that the history of how we've dealt with healthcare in the past points to probably taking somewhat of an incremental approach going forward. So with that, I'll turn it over to the next panel.
Thank you, Sharon, very much. Our next presenter is Dr. Dan Doyle, and I think many of you know Dr. Doyle. He's with New River Health Associates and Cabin Creek Health Systems. And he's going to share with us a perspective today on Coverage for All, discussing single-payer systems, Medicare for All, and universal health care. And again, this is another component, another piece of the puzzle as we try to reason our way forward, thinking about how we can capitalize on gains that we have made in coverage and access, and also protect those gains that we've made. Dr. Miller?
I don't like standing behind a podium. In some ways, after hearing Chris and Sharon talk, I'm not really sure what my job is here, but because I'm a physician and a healthcare provider who works at this, I guess I should talk about that. So I'll just say I'm a family physician. I'm now in my 41st year of doing primary care in West Virginia. And I think part of what's kept me going so long is the fact that so many people don't have access to care that they should have. And it's really hard to stop when you have the privilege day in and day out of being there for people who might not get seen any other way. I know I'm not the only primary care provider in West Virginia, but just being there and listening to people coming in and helping them solve incredible problems of access to all kinds of care. Every single day, I've always felt that the job of primary care provider is basically an impossible job. I mean, our job, day in and day out, is to do the impossible. When you see the combination of healthcare problems, social problems, financial problems, housing problems, family conflict, addiction, that are all rolled into one big ball, and people come in talking about how they're bleeding and passing out, and you just feel like this is impossible, and then you just keep going. That's kind of what we do in primary care. I think that there's kind of three things I would like to talk about. One of them is going to be about this little card that I'll go through with you in a second. But I want to pick up on two things that Chris talked about. He talked about, and Sharon also, that complexity was a big word. And then the other ones Chris talked about, agency. So, no question about it, healthcare is complex. But when we deal with complex problems and complex situations, one of our tools is to look and see if there are any principles that can help us find a path through those, or can help us. Chris warned us against reducing things down to simple solutions. But to me, there is something simple and that we can use in thinking about healthcare. And that is the notion that every person has a right to healthcare. And one way or another, so if I have a 10-year-old kid who fell off the slide on the playground and broke his arm, there is a simple question, which is whether he's going to get seen by an orthopedist or not. And if I have a 63-year-old person with a really bad hip who can't walk anymore, who has to wait 2 years for Medicare so they can get their hip replacement, still the question is, are they going to get what they need or not? And is somebody, and as a prisoner who's got right lower quadrant abdominal pain and throwing up, going to get surgery for his appendicitis or not? So to me, that actually makes my job pretty simple, and it makes the problem of healthcare. That is one simple thing that I try to hold on to every day. Probably everybody in this room agrees with Article 25 of the UN Declaration of Human Rights, that basic health care is a right for all persons. But we know that there's a whole bunch of people out there who don't agree with that. And Sharon had her point on her slide up there about one of the things that makes healthcare complex is the cultural conflict between, I think you called it social responsibility and individual responsibility. And so we know that there are many, many people who believe that healthcare is medical care is a commodity like anything else. If you go into McDonald's, you can't get a hamburger unless you have $1 or whatever they cost right now. And healthcare shouldn't be any different. If you can pay for it, you can get it, and if you can't pay for it, you don't get it. And we don't believe that. But based on walking the dirt roads of Kennard, West Virginia yesterday, Linda says I'm too loud. Walking the dirt roads of Kennard, West Virginia yesterday, knocking on doors and talking to people, what's clear is that there's a whole lot of people out there who do believe that everybody should have health care, but somehow are falling into the net and the trap of spokespersons and leaders whose package includes it's a commodity. So in that sense, Chris is right that this cannot be a single issue. It's tied to a whole bunch of other things. So that's my thought about the complexity of reforming healthcare, is that keeping some basic, simple principles in mind going forward. Another one, of course, is affordability. We can work on the complexity together. The second thing is, to introduce this little blue card, was Chris's point about agency. We do have agency, and for me, agency translates to organizing. I mean, there's policy work to do, there's legislative work to do, but for those of us who aren't political scientists or professors or elected legislators, we can organize. And so that's the purpose of this card. This is the cliff notes for what I have to say. And I'm hoping that you all will take this home, and as you exercise your agency with your family members and your church and your union and your workplace and your neighbors, that you keep these points in mind. So I'm going to run through this with you. This is something that I worked on sometime last year, and then Kathy Kunkel and Gary Zuckett helped with it and even agreed to own it. So they have their names at the bottom. Here are the names of their organizations at the bottom. So this is a Medicare for All organizer pocket card. Castell pointed out to us last week when we were talking about this that probably it would be better to say Medicaid for all and Medicare for all. And she's probably going to talk about that in a minute. But number one, healthcare is a human right. Article 25, United Nations Universal Declaration of Human Rights. The next thing, I don't like to talk about is having a healthcare system, because frankly, I don't think we have a healthcare system. We have a market-driven industry that in 2016 cost over $9,000 per U.S. citizen and still left 7% of the people out, something like 28 million. And mainly what it does is produce huge profits and huge salaries for CEOs of drug companies and pharmaceutical companies. Why is it so expensive? I pointed out there that the salaries are simply obscene. And those are just the top people. Then you have all the middle levels of management who are only making $1.5 million a year. What happens, most of you already know the point of how the premium dollar breaks down, or how the health insurance or healthcare coverage breaks down. With private insurance, 80% pays for actual care, 18% for administration, and 2.7% profit. With Medicare, 97% pays for medical care and 3% for administration. Still, millions are left uninsured or unable to afford care. And I'm going to resist the temptation to read through this whole thing, because the point of this is for you to use this as talking points, persuading people, explaining to people, talking to the people who want to talk about, as I walked around yesterday knocking on doors, people who want to talk about whatever Fox News has been pounding at them with, instead of thinking about healthcare. If you get the subject on healthcare, most people agree, I have found, agree with this. One of the things that's happened over the last few years, and the way things are going, it's likely to happen more and more, is more and more fake insurance plans are being offered to people. And by fake, I mean privately purchased insurance plans for people who don't qualify for Medicaid or Medicare or can't afford their employer-based insurance plans. So many people are working jobs where their employer offers a plan, but they can't afford that premium deduction, so they still don't have insurance. So then they go out in the private market, and as state and Congress more and more takes away requirements for insurance plans, people are getting so-called insurance plans that have very high deductibles, $26,000, $28,000. And my own son doesn't even want to go to the doctor because he knows he'll never meet the deductible, so it's like having no insurance at all for him. So the point is that many of the plans, that there has been a general trend for more and more of the cost of care to be shifted to workers and families, even when their employer offers plans. Medicare for all is possible, or another way to say it is health care coverage for all is possible. 60% of Americans in polling favor expanding Medicare to cover all. And then I listed the bills that are currently before Congress. H.R. 676, many of you know that used to be called the Conyers bill, and Congressman Conyers, I think he's gone now, or will be. But there's a new Democratic caucus that has taken on H.R. 676 and is continuing to organize for it in the House of Representatives. And then Senate 1804 is the Bernie Sanders Medicare Improvement or Medicare for All Act. So these measures are before Congress. The last thing I wanted to do is and Chantal cautioned us that we have to be very careful about how we talk about elections, so I will be very careful. We can't do partisan electioneering here. But, I mean, this is a great seminar, conversation, symposium that we're having here today, but to talk about expanding healthcare coverage right now, 2 weeks from an election, is a little bit like talking about adding a deck on the house while the front porch is burning and threatening to take down the rest of the house. We are in great danger of losing what we have. We are in great danger of losing Medicaid expansion in West Virginia and CHIP being jeopardized. So frankly, I would put away these blue cards. Don't waste your time on them until after November 9th, because what we should be doing right now is canvassing, writing, talking to people, getting them to vote, and explaining. Many people that we talk to will say that, well, yesterday, what we found is a lot of people aren't registered at all, we know that. Further you go up the hours, the less likely they are to be registered because they want to stay off the radar. But then there are many people, and many people said, I've never voted. But I also talked to a few people who are in their 60s and have just registered for the first time and are going to vote for the first time. And a lot of those people will say to you, well, they say, I don't know how to operate a voting machine, I'm not sure I'm going to go. But if they actually are going to vote, they'll say, who should I vote for? So if you have trusting relationships with people and you sit down and talk to them, you can have a big influence on whether they vote and what they vote for. And to me, in terms of protecting the whole house from burning down, or half the house of healthcare coverage from burning down, that should be our top priority right now.
Thank you very much, Dr. Doyle. Again, what really resonates are two things. One, understand that access is so crucial. Insurance coverage may not be enough. I think that's a big point that you're talking about, especially some of what's happening in the private marketplace. The other is this aspect of agency. And Dr. Doyle certainly has been a catalyst for change. And when we think about agency, we think about the importance of participation in the process. We've been able to get a sense of context today. We've been able to get a sense of how we got to where we are through Sharon's discussion and what might lie ahead. Dr. Doyle's helped to expand upon that, talking about some particular policy solutions, which are really gaining a lot of traction. Medicare for All in its different guises and different dimensions is really gaining a lot of traction right now at the national level. And it's worth our consideration, very much so. We also realize that what is happening in the other states and at the federal level is absolutely crucial for us to understand not only the opportunities that might be ahead, but also to understand how developments may pose certain challenges, even challenges to gains that have been made. To provide perspective on that is an individual who knows so well what has happened in our state, but also at the federal level. And like so many West Virginians, is dedicated to paying it forward, in my opinion, helping to share knowledge and expertise and passion about a topic that is so crucial to us, of course, in talking about healthcare. So Kat Stoll is Policy Director for West Virginians for Affordable Healthcare, and she's also the Campaign Director for West Virginians Together for Medicaid. In the time that I've known Kat, I've really become dependent upon her for what's happening in Washington, what's happening at the national level, what's happening in the other states and here at home. She brings a very unique, highly qualified perspective in terms of her knowledge and her experience, her expertise of what's happening with the healthcare, looking at healthcare at the state and national level, and I welcome you to put it.
Thank you, Chris. Can you all hear me okay? Yes. Good. Gosh, it's kind of hard to know where to go after those three. You know, it's like Chris gave us the framework, the big picture. Sharon told us the story of incremental progress in our country. Then Dan gave us a vision for where we should go. And it's a simple but vital and vibrant vision. And now I'm supposed to bring it all together. So I'm going to try to do that. It's very challenging. The first, and please, I'm sorry about the glasses, but I'm getting used to these. The first point that I want to say, and it's really to reiterate it because we've heard it, is that we in this room are all on the same team. And we all must work together. Whether you label yourself an incrementalist and believe that you have to take small steps in this country towards a goal, or whether you are a single-payer advocate, we are all on the same team if you think about the landscape of politics in this country today, and we must work together. And I heard that today from Dan with his comments about Medicaid. Now, I think it is important that every person in this room understand that we, every one of us, wherever we work, share a vision of affordable health care for all Americans. That's why we're here today on a Sunday. And we share something else, and this is what I think is really important. We share a belief in a legitimate, positive role for government in achieving quality, affordable health care for all Americans. And I think there are forces out there. There are some in this country right now who would not only undermine the vision of healthcare as an essential right, as Dan put it, but also are and have been under a long-term, orchestrated, deliberate plan to make us believe that government has no good role in our country. That government, big government is bad. And that government cannot have a positive role in our lives. So at the same time, I'm going to talk about that a little bit more, but I also want to remind us, as Dan did at the end of his presentation, that we are forced to play defensive in this country right now. None of us want to play defensive, but we are. We are forced to play defensive, and we have to be united. Every one of us united against threats to the very foundation of the vision Dan presented of quality, affordable health care for all. And I believe that foundation right now in our country is Medicaid. We have 33 states now that have expanded Medicaid. We have 3 more that have it on a ballot initiative. Those states are, if you're curious, Idaho, Nebraska, and Utah. The people have said we're going to put it on the ballot because we can't get our state legislature to expand Medicaid. And if you think about Medicaid, especially in the context of the Medicaid expansion, that we were one of the first states to adopt here in West Virginia, that is a form of single-payer, universal health care for people under 138% of poverty, which is about 34,000 for a family of 4. And in my world, in West Virginia, in Morgan County, 34,000 is middle class. So we have achieved an important, tremendous goal. If you'd have asked me in 93 or 98, when I was part of the Clinton team, if we would see Medicaid at that level in 33 states, I would have laughed. When we put together the Obama package, we thought we were crazy asking for 100%. And we got Medicaid, the option to take Medicaid in all our states, 138% of poverty. That is a tremendous accomplishment and a huge step forward towards Dan's vision of a universal single-payer system. Now, I want to talk again, as I started before, about those who oppose us. You know, I don't think they just oppose health care for all. They are operating in the context of a larger philosophy that each and every single one of you and everyone in this country has their own fate in their own hands. And that the government of the people has no obligation to help those who were not born with economic advantages. That is where we're at. That is what they are selling. And it's not just a pull yourself up by your bootstraps philosophy. It's a lot harsher than that. If you are born with boots, you are morally flawed. That is what we have to counter. So in that context, I would suggest that those in this room have 3 challenges. And that is building off my speakers that I shared this panel with. First, we need to promote a vision. Vision is important. You've got to know where you're going long term. Promote a vision of a truly universal, affordable health care system. And that's Dan's card. He's given you a tool. You have to engage in long-term messaging work, tough messaging work, mindset changing work that reestablishes in our country and among our neighbors a sense of community. And that government is here to help the collective whole advance. And if we don't take on that long-term, mindset-changing battle in every fight we take on in this country, we will lose in the long term. And the third thing we have to do is unite against the current threat, the imminent threat to Medicaid and the Affordable Care Act. So with that, let me talk a little bit about what the threats are. And there's 2, and you all know this. There's the federal budget right now, that's one threat, and the second threat is the court system, and we've been talking a lot about that lately. The federal budget, to me, is quite simple. Those in power passed a tax bill to give huge tax breaks to wealthy corporations. And of course, they wanted to line the pockets of some in our country, but there was more going on than that. That bill and that tax law that passed is about starving government. There is now less revenue and a larger budget deficit. And that budget deficit, created by the tax cuts, becomes the reason to cut public programs, social support programs, and the bullseye for them is the Medicaid program. So it's not just about tax cuts, it's about starving government, and now who and how do we reduce the budget deficit? We turn to Medicaid. We see a fight next year and the following year about cutting Medicaid. And they won't talk about cutting federal dollars to Medicaid. They'll talk about things like state flexibility. Who doesn't want that? They'll talk about per capita caps and block grants. It doesn't matter how they word it. You can spend time explaining those. I've spent a lifetime explaining those things. But the bottom line is we have to decode that for our friends and neighbors and family who rely on Medicaid and rely on the ACA's premium subsidies and the cost-sharing subsidies. We have to decode it as cuts, that we are cutting these programs. The courts, I'm not even going to talk about that. We know the court has now been tilted to the right. It may be tilted even farther. I don't know that there's a lot we can do about Texas versus the United States when it goes to the Supreme Court. And the fact that we lost that battle is, I think, discouraging, exhausting, frustrating, infuriating. I get up in the morning and I scream. How many of you get up in the morning and scream? We're not out I could pick on a few more of you. But we cannot be overwhelmed. We cannot give up. We can still work towards Dan's vision, even if we do it in Sharon, as she's pointed out, our country likes to do baby steps, incremental. We have to stay really engaged. And I echo Dan, electoral politics have never been more important. If you're not out there working on voter registration campaigns, do it. Take a week off and do it. I don't care what you do. There is nothing more important now than voter registration and getting folks out. So the one other thing that I want to talk about, there might be a couple things, but I'll try to get through this quickly, is middle-class Medicaid envy. If you saw me speak at the Medicaid Summit, I talked about this. What is middle-class Medicaid envy? We have it in West Virginia. I have it. I'm guilty. I've got it, envy. If you look at the polling data that I've been looking at lately, we now have about 80% of Americans of both parties, Republican and Democrat, who know the difference between Medicaid and Medicare, and who like Medicaid. 80% favorable polling on Medicaid, and it looks like that here in West Virginia. At the same time, when you ask a voter, what's your top issue? They'll say health care. After that, jobs and the economy. Healthcare is still our #1 voting issue. When you dig deeper into that with the polls, you find out it is a real fear of unexpected medical costs and bills. 70% of the voters who say healthcare is their top issue also say they are afraid they will have an unexpected medical expense and it will destroy their family. 40% of voters, both parties, have had an unexpected medical bill in the last year. So it's a real fear. Now, combine that fear that the bill will come in, the child will get hurt, you will get sick. And you combine that with 80% of us are saying, hey, Medicaid looks kind of cool. 1/3 of us in our state, whether we're dual eligible or not, but 1/3 of us rely on Medicaid. And the other 2/3 of us are looking at that 1/3 going, I want what you got. That is looking pretty good to me. I have real stories in my county over and over again where working folks who do not have Medicaid are touching the lives of family members and neighbors on Medicaid who are saying, that looks really good. Now, Medicaid, middle class envy, can be our friend. It has created a vision of government doing something positive to help our neighbors, friends, and family, or it could become resentment. It could be, why do they get it if I don't? I'll work hard. And it is up to all of us to frame this in such a way when we talk to our neighbors, friends, and family, don't resent. Fight to get it too. Don't resent what others have. Let's work towards making sure more of us have it. And that is an enormous challenge. There is no harder challenge. policy, I'll just touch on a couple other things. First of all, the term Medicare for All is a messaging tool. So any of you who are even the slightest inclined to go, I don't want Medicare for All. Medicare is a Medicare Advantage, it's a crappy program, it's full of high out-of-pocket costs. Medicare for All is a brilliant messaging tool. So I'll just say that, we can talk about that more. And they've done polling. And when you talk about a single-payer system, people don't like it. When you talk about Medicare for All, they do. So keep that in mind. It is not a policy blueprint. It's a rallying cry. And I embrace it for that reason. If you want a policy blueprint, I'll bore you to death. I think we have room to explore some things in the states, in those state laboratories that other speakers have talked about, to advance our vision, but probably in some incremental steps. Some of those are pretty large incremental steps, and they're real challenges for us. One would be a Medicaid buy-in policy. So what's that? I'm just going to talk briefly. If a consumer with income too high for Medicaid wanted to have something quality and more affordable, they might be able to buy into Medicaid, or very much a Medicaid-like program. To do that, you need things like a Section 1332 waiver, and you have a lot of complications. But basically, you're taking the premium subsidies that we give people up to $400 and letting them use that to buy into Medicaid. And it has a lot of advantages for the Medicaid program and for the people who would use it. Medicaid buy-in. Am I saying that's the right policy? No, I'm saying it's one we should explore together as a possible next step. There are other states looking at it. Basic health program. Basic health program is part of the ACA. It is a tool by which you can take Medicaid up to 200% instead of 138%. New York is playing with this one. A third idea might be a public reinsurance program. And I would suggest it should only be for gold plans in the health insurance ACA marketplace. Only the gold plans with the low deductibles, but then help drop the premium for the gold plans for more people. So you can think of it as a state doing additional subsidy money, or you can think of it as reinsurance, a little bit more palatable to some. We have Minnesota and Maryland pursuing some of that. Some of these ideas, like a public reinsurance program, have been embraced in some ways by both parties. So there's a lot to look at there. So the point here is that we have opportunities to use the ACA and the Medicaid expansion to illustrate our vision, and we have opportunities to think about how to build on the Medicaid foundation in incremental steps at the state level. What does it take to get it done at the state level? It takes political will and money, and those are huge. Revenue, and so we all have to engage in the dialogue in the state about new revenues. And there's a lot of them on the table. I won't enumerate them. But if we are not part of the demand for new revenue, new taxes, if you will, whether we call them assessments or whatever, we must be part of that dialogue. It takes money to get a lot of this done. It also takes political will, which takes us right back to every one of you engaged in electoral politics, so that we put the people who are allies into office. Now, just in closing, there's one other thing I want to talk about. What I consider right now in this country and in this state, the most effective advocacy strategy besides voter registration. And get out and vote. Look at Gary, because he does so much great work. And Gary, I hope everyone saw your card. That's a tool to help people know where to go to vote, how to register. There is nothing more important than that card if you care about healthcare for all. The other important strategy is stories, real stories. They have lots of money to run lots of ads, but we in West Virginia have the faces and the stories of our friends, family, and neighbors. community and a sense of decency in the healthcare debate, and we need that right now. In your packet, there's a card that helps tell you how you can share your story or people you know's stories. Laura Foster's in the background conveniently standing up with a baseball cap on, which always wears her baseball cap. She is our story collection coordinator at West Virginians for Affordable Health Care. She works full-time at story collection. That's how important we think it is. She's doing a great job. So I just want to end with telling you a little story about my friend Mary. How many of you watch Fox News? The Bret Baier special report? Well, like nobody. That's okay, because you're not my target audience. Bret Baier's special report on Fox News featured the story of a woman named Mary Kiesecker who lives in West Virginia on the National News Report talking about the healthcare debate. And they had several policy wonks and a electoral analysis that was pretty boring, and I actually can't even remember myself what they blabbed on about. But then interwoven with what would have been those who are opposed to universal health care was Mary. Mary just a person who lost her job at Fleetwood making trailers and went for 12 years without health insurance, right? And so then she finally went to the doctor right after the Medicaid expansion happened in West Virginia, got some health care work done, and they said, get a mammogram, Mary. You haven't had one in 12 years. She got the mammogram, and you can guess, found that she had breast cancer. But she also was covered under the Medicaid expansion. She's self-employed. She has a decent income, but she's under Medicaid eligibility, under the expansion. And so thanks to Medicaid, her life was saved. She got the breast cancer treatment she needed in Morgantown and is now a survivor. So that's a wonderful Medicaid success story, but what's even better about this story is what she did now that she has seen what it did for her. She's become a Medicaid advocate, and you can ask Foster about this. She agreed to tell her story on Fox News, and let me tell you, all her friends and family watch Fox News. In fact, her brother said, that's my favorite show, Bret Baier. And there she was, telling her story and saying, this is wrong. Everyone in this country should have affordable health care. That was her bottom line message. And she has never voted before in her life. And this year, she is now working at voter registration, and she will vote, and all her friends that never voted before will be dragged to the polls. Because she now sees the relevance in her life, and her friends' lives, family, and neighbors, of being engaged, that politics matter, voting matters, and in fact, she can help save her own life down the road. So that's Mary's story, and it gives me great hope to think how activated someone who never followed politics has become. And her family has become activated. And her neighbors have become activated. So we have a current going with the Medicaid expansion that we can build on. As long as we don't lose that, we are on the road to universal health care for all. And I think it will probably be more close to a single-payer system than I ever thought possible. So that's my messages to you, and I hope I help bring it all back together. Thank you.
Thank you so much, Kat. It's almost as if we want to be able to turn Medicaid envy into Medicare, Medicaid envy into Medicaid admiration. Right? You know, we admire those things and we want to emulate those. I have the privilege of helping to moderate the questions, the Q&A. So, Gail.
I do have a question, and it's speaking to what Kat was talking about. My husband showed me something in the newspaper that is saying that a vote for or a support of Medicare for all would be devastatingly bad for seniors. And why I raise that as an issue is it's an issue of framing and it's an issue of credibility. That here is somebody who's raising a very, very potent voice that lots of people listen to. And I think those of us who support Medicare for all would say it needs to be fact checked very, very quickly. How do we frame? How do you speak to issues of those of us who are on Medicare and say that Medicare for all is not a threat to seniors, that to expand what we have not only does not hurt us, but actually will help more of the people that we love and care about?
So why don't we hear from Dr. Doyle, if you would mind addressing that?
Okay, so I think you were commenting on an op-ed that came out today claiming that Medicare for all would be devastating for seniors. Well, if you were my patient and you came in and you were telling me that in the exam room, and we do have some of these conversations in the exam room, I think I would probably say to you, consider the source. This is another great example of using fear to confuse and divide people. And then I would say, there is no reason in the world why giving health care like Medicare or Medicaid to more people means it has to be taken away from you or other people. That's a choice. And so I see this as mainly fear-mongering for political gain with no basis in reality. It's up to the Congress to decide that. Personally, I think we can afford that everybody has either Medicare or Medicaid coverage. This is nonsense.
Kat, would you like to respond?
Well, one of the things that strikes me about that is when you talk to people who are on Medicare, who are not wealthy, they are very aware of the fact that they have to buy a Medicare supplemental plan. They have to buy Part D to cover their prescription drugs. There are a lot of out-of-pocket costs associated with Medicare in our country. It is, as I said, not necessarily a model for what I would want Medicare for all to look like. That is a messaging tool. I guess I'll lean forward if I put that. It is a shorthand for a vision. But I would say to someone, we have the potential to improve Medicare for seniors. We have the potential to have a better Medicare program for seniors if it was a program that we all had. That we would have more political strength if we were all fighting for this same program. Instead of being divided into seniors versus poor folks versus people with disabilities versus etc. And the politics today, as Dan said, is politics of division and fear. But what we really want to say is, why can't we all come together to have more power, to have Medicare, and Medicare with fewer holes for everyone?
I'd just like to say this just points out where complexity does get used against us. And as Dr. Doyle said, that's just the worst kind of fear-mongering. I mean, there's no stronger advocates for Medicare than seniors, so to strike fear among that group is really would be a great division for those who don't want to have health care. That's why it's so important that together, which is one of the reasons we had this forum, because we know this is going to be such a major battle in the next couple of years, both to support Medicaid and to support Medicare, and to find the path forward for how do we cover all and how do we make it accessible. High deductible plans where you have to spend $500 or $1,000 before you even get to use your coverage is not an accessible plan. So we have a really big challenge before us. And I'd just like to remind you all that for those of you who can't think back to the Clinton era, I'm sure almost everybody remembers the Harry and Louise Act. The insurance industry spent, it's estimated, over $100 million to defeat Clinton health care. That was back in the 90s. Can you imagine now, post Citizens United, how much will go into defeating anything? Even in this cycle right now, we're hearing talk about having to defeat the coming wave of socialism. There will be that, the socialism boogeyman. So I think we really have to be clear about what our goals and stepping stones are. And when people start to talk about single payer, that's where we might ultimately end up, but it could be a bridge too far in how we defeat ourselves. Okay.
Yes. So it's always great when you have a panel presentations and the questions come back and the conversation starts to anticipate some of the other questions that we have. I would like to add one aspect, Gail, to this question on Medicare for All. And we mentioned early on that this notion is gaining traction. And you know something is gaining traction at the federal level when you have many different proposals that are being offered. And so even as a starting point for conversation, we talk about Medicare for All, that does have a certain rhetorical weight to it, but there are a number of different proposals out there, including buy-in programs, age limitation, what have you. It's a topic that's on the table right now, and it really does bear further scrutiny. Because if we think about gains in healthcare coverage in the United States, oftentimes it's been that platform of Medicare, especially Medicaid, which leads to the next question. And Kat, I'm going to direct this to you first, if that's okay. And that is, why do people prefer Medicaid over Medicare? What are its benefits, advantages, or disadvantages? And so there's one individual at least who has the sentiment that perhaps Medicaid is the preferred model.
Okay. I wonder if you, oh, it sounds a little better now. Medicaid has much, I'm going to turn this off. Okay, can you hear me? Yeah, that's better.
Feel free to use the mic too if you want.
Yeah.
Maybe use that one.
So if you can hear me, I'm going to set aside the mic. Medicaid is low or no premiums, and I'm talking low like dollars. Medicaid is got very few, it has no deductibles or very low deductibles, very little if any cost sharing. It is comprehensive in what it covers. Medicare has high deductibles, has premiums, has co-pays, and it has been, I think, somewhat distorted from its original vision by Medicare Advantage private insurance plans. So in some ways, I like the Medicaid vision. Now, I can't imagine rallying, my family around Medicaid for all just yet. And I think Medicare for all is an important rallying cry, not only because it's a vision of affordable care, but it's also, in spite of a few people who have said, keep the government out of my Medicare, which is always cracked me up. Most people understand that Medicare is a government program and it's good. That and Social Security. So you get a twofer out of that. You get the sense of a universal system and one that the government plays a significant role in and does successfully. And most people, I think, will get that. If you get to Medicaid, they're not going to understand it. If you asked me to design a blueprint for healthcare reform, it would look much more like Medicaid because that is affordable. I also think an important quality of a path to universal affordable health care is one where you give middle class and even higher income families the same program you give low income people. And that is expensive. But then you don't have both supporting the low-income program. You get universal support, which is what we really have for Medicare, across economic classes, and that becomes really important. If you have to subsidize some low-income folks to get a little bit more, that's fine, but you want a system that goes across the classes. So that's, you know, one of the things I don't like about Medicaid is that income eligibility and Medicare is not. So I like the details of Medicaid better, but I like it across the classes characteristic of Medicare.
Someone to follow up. Okay. You'll blow everybody. It's my understanding, and I may be wrong, that Medicaid patients have a hard time being seen by a doctor. That's number one. And number two, when my son was on Medicaid recently, he could not travel out of state. He was in Virginia, and they would not take him in an emergency room or his doctor. Well, they took him, but he had to pay. He'll be paying for years. So I don't. That's the kind of thing that kind of puzzles me about preferred Medicaid.
Okay.
It's free, but it's limited.
Those are excellent points. Is Medicaid a perfect program? No. Is Medicare a perfect program? No. Will any single payer or other universal healthcare system we create be perfect? No. Is the Canadian system perfect? I know we have a gentleman in here from Canada. No, it won't be. One of the problems with Medicaid is questions that come up about network and who will take Medicaid and who won't among providers or doctors. Actually, I've looked at the network in West Virginia, and it's very, very robust. And when a third of us are on Medicaid, the doctors are going to flood. The reimbursement levels are lower in Medicaid. That's one reason why Medicaid is cheaper, if you will. And that is an issue because providers don't want to be paid less. On the other hand, a lot of systems in other countries rely on cost controls for providers, whether it's a hospital or a doctor. And so that's a really difficult path for us in our country. But yes, where we see pockets of network adequacy, I would also suggest that there are pockets of private insurance network inadequacies. If any of you have not experienced the out-of-network phenomenon in a private managed care organization, it is real. I mean, I can tell you my own story of not having my anesthesiologist covered by my insurance the same way my hospital was. So I had to navigate through that with private insurance. So that's network issues. If you have only one system, everybody's going, what? That's just common sense. That is the simplicity that Dan talks about. As far as Medicaid and going out of state, Medicaid is a state-based program, and there are issues there. If you're in my area of West Virginia, you can go to Winchester, Virginia and get care. There are exceptions, but it is basically a state program. Federal matching dollars, some state dollars. So that's not universal across state lines, although again, there are some exceptions. So there again, you want a universal system.
So the question is a very good question because we do essentially have 51 different Medicaid systems in the country. I mean, there are foundational common elements to all of them. But as we move forward, that is one of the things that we struggle with. But it also has been that diversity of state systems that has allowed for a lot of innovation to be done. Sharon.
I just wanted to say, I think what Kat's pointing to is, and what you're saying is correct, is that with Medicaid, we currently do not have a national guaranteed benefit level, and that was exacerbated by the Supreme Court decision. I think you said your son went to Virginia.
He's in Virginia. And when he
Virginia
came back,
does not, Virginia, like 20-some states, does not have that expansion. So that's one important criteria. We would have to campaign and work for a national level. But your other point about coverage or physicians accepting Medicaid, by and large, Medicaid is highly accepted in primary care. It's usually in specialty care where you run into issues.
And again, this points out the difference between coverage and access barriers can be in many different ways. This conversation actually morphs nicely into a question that was asked, and I want to present it to all of you, perhaps asking Dan to take the first shot at this, and that is it a myth that our health care will be rationed or of poor quality if we have Medicare for all? So, and we've heard this concern over time with the single-payer system or other reforms that have been proposed, that somehow health care will be rationed. It's certainly a big part of the debates in the early 1990s again, during the lead up to the ACA. So Dan, do you want to address that?
I would like to hand this off to somebody in the audience. I feel like we have lots of experts here who could comment. So I'd like to invite, and I mean, I know who some of the experts are, but there's other people I don't know who might be just as much. So because I would like to try to hear more from some of you.
Repeat the question for the audience.
If you don't step up, I'm going to call on you.
We're gathering that, Dan. Is it a myth that our health care will be rationed or poor quality if we have Medicare for all? Or will it be too expensive?
Such BS, you know. We have the most expensive healthcare in the world. We're the only country that really does ration healthcare. Other countries pay much less. They have much better systems. They have better health outcomes. We have got to have a national solution. It could be public, it could be public-private, whatever, but other countries have been able to do this. They've come together. They're doing much better. They're paying much less. So this is just BS.
Full disclosure, I'm Canadian, born and raised. I've started a new manufacturing business, and I'd like to hear more talk about the economics of healthcare. Number one, the bankruptcy rates in this country are through the roof and are almost zero in Canada. But number two, I'm in the aerospace field, manufacturing. We invented a system, we wanted to work here, but I had a top executive of a major aerospace firm in West Virginia telling me, Alan, why aren't you going to Canada? Because your payroll burden due to health care will be 15 to 18% lower. That's a sheer global economic fact.
It's a wonderful comment because I think we recognize very much that healthcare is not, it has spillover effects to other areas of our economy, but more importantly, healthcare is a community development question. It's an economic question and it's a community development question. And I think we know that's so low in our own state. You talk about walking those dirt roads. A few months ago, I was driving through a small town and I saw the vacant lot where the community hospital once was. Sir, you're absolutely correct that we need to nest or embed discussions of healthcare policy and reform, quality, access, and care in these larger economic questions about economic development and about community development. And it's not simply the multiplier effect of a Medicaid dollar or a multiplier effect of a Medicare dollar. It's important as they are. It's about creating that overall infrastructure, that quality of life, and that climate that's necessary for community and economic development.
Chris, can I get two more responses on this side?
I was on the ration question. Part of the problem in this country is we provide too much care. And what we are trying to find is a system, and I think it's much more likely to do it with more governmental intervention that uses the right amount of care rather than too much or too little. And so what we see in other countries, Canada is probably an example, certainly the United Kingdom is another example, where they spend less for health care, but they have better results in terms of the metrics that we usually use to assess what care folks are getting, like life expectancy, like mortality, rates of diabetes, rates of hypertension. And those are what we should be looking at. And with an overall system where these things are looked at more carefully, you might call it rationing if you can't get something that you don't need. But I think if that is, it's far less likely that you will not get something that you need than that you will get something that you don't need in a system that has more overall regulation from an oversight sense like the federal government.
So I'm the other foster, that's the cool one, I'm just the story one. When we talk about the myth of the rationing, the healthcare system itself, you're dead on, Chris, when you talk about the community development question. When we're looking at healthcare versus, get ready for this word, prevention and wellness, that's the discussion in which we talk about what is true healthcare. Because if we don't have to go out and get those, when you talk about too much care, the care that you actually need versus the care that you think you need or the care that you're going to get. Now, I'm not a practitioner, and I praise you guys. I work with Dr. Mark Picazello sometimes, and he just released his book, Run for Your Life, and he talks about what it takes beforehand, breaking that cycle before you get to the necessary health care. So when we talk about diabetes, type 2 diabetes specifically, what are we going to do? I have a story from a gentleman which I collected just the other day, and I have to keep it very brief because I have to ask permission all the time from the storytellers, but talking about how he takes 10 medications, 10 pills, and 2 shots a day. That ends up being somewhere around $1,600 a month. This is a Medicaid story. Without that, and I'll check the website because the story's going to be up soon. Without that, individuals would die. But where do we get before that situation? So when we talk about myths and rationing healthcare, I'm going to challenge changing the entire system. Because I think I'm the only one in my 30s here today, and I love the wisdom that's around. But when it comes to my age group and people that I'm dealing with, there's a question up there that I posed to you, Chris, talking about the infrastructure and our systems change. Instead of saying healthcare, talking about, okay, well, let's get this pharmaceutical, let's get this, specific treatment. What about the prevention that goes into it beforehand? So you don't have to rely on that. And again, breaking the rules here, talking about taking pills, I'm challenging the systems because if you take care of it in the front end, you might not have to worry about those specific complications in the back. So you can actually say, okay, well, let's search for Alzheimer's solutions. Let's really the diseases that we haven't found solutions for when we know the answer to some of the chronic diseases and how do we prevent those?
So I don't want you to feel alone. My virtual age is 37. But your questions are very, very important. And I think it also comes back to more systemic issue and comment, and it's reflected in some of the note cards that are up here. That healthcare is not only about the end result of treatment, it's about health promotion, disease prevention, etc. I think what Dr. Foster was talking about is very, very important. How do we align expectations and needs to the resources that we have? And I think that's part of what we're talking about. The questions that we have about how we can find common ground, how can we move forward? I actually think your comment about healthcare promotion and wellness is a very important part of getting towards that. Because there we can talk about what we want to see for the future of our country and what we want to see for the future of West Virginia. I'm being mindful of time, but I do have 2 questions that I think can pull us together. I'm going to read just those questions, and then I would invite Sharon to start the responses. The first is finding common ground between opponents to and advocates for healthcare for all. It was mentioned several times today. What is the potential common ground? I'm going to pull that question back just a little bit and really about how do you find common ground between opponents and advocates. Now I want Sharon to address this in part because, Sharon, you implemented a program, a management program in West Virginia, which had a lot of support, but also had some resistance. There were times, I'm certain, where people thought you were doing a fantastic job, and other times people were asking, why aren't we doing more quickly? And so one of the things about finding common ground is I think we would actually benefit a bit from your perspective on this. How do we find common ground between advocates, critics, opponents, proponents? Basically, how do we find that space for discussion? And I would like to start with you, and then Dan, and then Kat.
I think one of the strongest things that we have going for us in this whole discussion is that maybe unlike other areas of policy, healthcare comes down to personal. I think we all experience the need for healthcare. We all have relatives or friends. I think that that's something that can bring us together, opponents and advocates in developing consensus. I saw that a bit during CHIP. I remember early on in my years as CHIP director, we had a survey that was sent out, and I asked the folks who were participating in CHIP to say what was most important to them. And one mother wrote back and said, I like it that we have something for working people. And it's been unfortunate, actually, I think, in the area of children. You would think, if anything, we could come together for children, and CHIP as a program did benefit from that. But I think the more we can lay common ground, and in a sense, the success of the ACA has done that too, because more people have benefited from Medicaid coverage. I think because, as terrible as it is, the opioid crisis hitting in West Virginia, I think we can come together to say why it's important that we have a standard of coverage for all. And I'll just let you folks.
Okay, I'll talk. This is an incredibly difficult question, and the question operates at the system at the macro level, and also kind of at the interpersonal micro level. I don't know how to find common ground with the commentator on Fox TV who's talking at me and millions of other people, because it's not a two-way conversation, it's a one-way conversation, and that's how it's intended. So in terms of trolling and astroturf, whatever you call that, astroturf movements, I don't have the answer. I do think that common ground can be built at the personal level, and I can talk to someone who watches Fox News all day long and is spouting half of it. Generally, the best time to talk to that person is when I'm able to be helpful to them in some way, or I'm able to provide some important service to them, or they're dealing with a family situation or crisis. So I have common ground. That's one of the great things about my job, is that there is common ground in the personal. And that relates to something that Chris talked about early on, about the importance of maintaining civil, empathic, respectful, never giving up discourse. Because if we don't do that, we know a whole lot of people who are choosing actually the opposite of that, because it's about winning. So I think that's my answer. I know how to find common ground in the personal. It's exactly the kind of conversation that Chris talked about. And I don't have the answer for creating common ground in the blogosphere and in the super media world.
I think we understand that. When I pitched Mary's story to Fox News, I did that in part because the producer of this particular show's wife is dealing with breast cancer. His name is Lee Ross. And so I knew that a story about a woman with breast cancer might crack open a bit the potential to talk to some folks who aren't normally our allies. So I go back to personal stories. On the policy side, I think we need to be creative and open to new ideas. At one point, there was a proposal circulating in Washington to provide a card to everyone that would provide preventive tests are free. But it would be not by any income. It wouldn't, it would be, you would move the employer-based system to a system where insurers would insure for catastrophic care, for hospitalization, and you would move into the hands of those evil folks in government, the providing for preventive care, annual checkups, some basic services beyond prevention. So you start to crack open the idea of what government can do for you. And then you would buy, it would be sort of like buying a Medicare supplemental, but a little bit more. You wouldn't get all the way, but you'd be taking yourself down the path, or whatever we have, towards that vision. A positive role for government in providing for a common need. So ideas like that, that one kind of didn't go anywhere at the time. But things like that could be where you would cross the aisle, because there's a lot of lip service given to this need to orient our healthcare system towards prevention and wellness. And that's providers on both sides of the partisan split. That's policymakers. Everybody's talking, choosing wisely, doing prevention, and so maybe there's something there. That's just one idea. But that openness to some creative ideas like that might something we could build a campaign around that might be less scary to a lot of folks than completely turning over the employer-based healthcare system, but just carving out a piece of it. There's an idea.
Thank you all very much. And we do have to have these discussions in the policy arena, within community, and the challenges are great. I know from my experience in working in communities, one way to get people to find some common ground is to talk about the generations to come. Children and grandchildren, what sort of world you want them to see. I know that sounds trite and cliche, but it's a very real truth. The other is to continue to have conversations and interact and realize a community of interest has many different members and many different perspectives. I am at heart an optimist. I'm seeing the sun peek through. What was a cold and gloomy West Virginia morning. And I think we've been able to cover a lot of ground today and to have a lot of perspective. It's a little after 4 o'clock. I'm certain that the panelists and others here in the room would be happy to have some of the stuff that you have back there, Chantel, right? And to have some further discussion on an informal basis. I apologize to those whose questions that we did not get to, but there were so many common themes that I think that perhaps you saw threads of your questions answered in the broad and fruitful discussion that we had. I want to thank our panelists. The sponsors for today's event, which include West Virginians for Affordable Health Care, the Kanawha Valley Village People, the Fair Shake Network, and the West Virginia Citizens Action Group. So thank you all for being here today, and
Create West Virginia.
And Create West Virginia. I'm just reading off of this agenda. Fantastic. Okay, thank you, Create West Virginia as well, and thank you all. Please stick around for some informal conversation and some refreshments.